Ji, Assalamu alaikum. My name is Dr. Imran Al Hassan. First of all, thank you very much indeed for inviting me to talk to you. And please accept my apologies for not being able physically to be with you in the meeting due to some urgent travel plans. I have put my email down because I don't know what will be talked about in other talks actually. And if my talk creates any confusion as a result of that, please don't hesitate to drop me a line and I will try my best to get back to you. During the talk, we will I'll put forward a case to set the scene really, and then we'll talk about the significance of ILD in systemic sclerosis. How do we risk stratify patients, how to select treatment, and then a couple of slides at the end about pulmonary hypertension and methotrexate. So this is a 46-year-old lady I saw probably 2.5 years ago. She was already known to a local rheumatologist with systemic sclerosis, but was referred to me by her GP as she developed some cough and breathlessness for a few weeks. Apart from smoking, she did not have any exposures or any significant past medical history other than systemic sclerosis, and perhaps GERD was part of that for which she was taking PPI. She was not sure what other medication she was taking. Uh, she had a spirometry on the day and her FVC was 82% predicted, which is within normal limits, and a chest X-ray done in the clinic was also clear. So when you come across such a patient, you wonder whether to investigate this patient further. How do we investigate? How do we know this patient is at risk of progression in her disease? And when should we consider treatment and what are the treatment options? So we will try to address all these questions in the talk later today. Just briefly about interstitial lung disease. This is really a diverse and heterogeneous group of diseases with very diverse etiologies, including exposures, drugs, environmental factors, and a large group of idiopathic, but more importantly, connective tissue or autoimmune associated diseases, which will be our focus today. So this slide is somewhat intimidating, but to simplify it, we can divide ILD into three large groups. One is exposure related, one is the idiopathic like IPF, etc. And in the middle here is the autoimmune associated interstitial lung disease, for example, rheumatoid or systemic lupus, etc. Um, ILD is a frequent complication of CTDs. In fact, within the ILD category, 15% or so of the ILDs are in fact due to autoimmune or connective tissue diseases. And systemic sclerosis is a condition in which ILD frequency is very high, and almost 50% or so patients develop significant, clinically significant ILD as part of the disease. Why is it important? Is it really important that somebody with a systemic sclerosis or somebody with connective tissue disease has ILD, or is it just that some people have indolent ILD associated with other conditions or drugs, etc.? We know from the data, and it is well established now, that people who have connective tissue diseases and ILD are actually worse off. It is an independent morbidity and mortality factor, and patients have poor prognosis. Some patients who may have features of autoimmune disease but may not actually qualify for a formal diagnosis as such of CTD may actually just have what we call now as lung predominant form of CTD, where only lungs are involved. And we also know that approximately 10% of patients who later on go on to develop CTD may just present initially with interstitial process in the lungs. Over the years, mortality in systemic sclerosis has not changed dramatically. However, the cause of mortality has, and now ILD and pulmonary hypertension is the leading cause of death amongst patients with systemic sclerosis. Systemic sclerosis associated ILD is a very common feature in these patients. In fact, if although chest X-ray initially may be normal and is generally a poor screening test. We'll briefly come to that later on in the study. But if we do scan, we find lots of abnormalities, and two-thirds of patients may have an abnormal HRCT. A very high percentage of patients will have abnormal lung function in the form of impaired FVC or gas transfer, DLCO. Um, Patients with diffuse disease are more at risk of ILD, and patients with anticentromere antibody or limited disease actually are more at risk of pulmonary hypertension, and it is thought that relatively they are protected against ILD. However, this condition can be fatal. It is important to know that skin manifestations, although they are a predictor of risk and all that, however, the skin changes do not actually mirror the changes or abnormalities in lungs. What are the risk factors for progression? Although systemic sclerosis is predominantly female disease with 4 times more common in females compared to men, however, male gender is a risk factor, similarly active smoking status, and if the disease onset is in older age. If ILD process starts early on in the disease, up to 5 years, but particularly within 2 years, that's also a sign of progressive disease. Patients with anti-topoisomerase antibodies, patients with impaired lung function or decline in lung function are also associated with progression in the disease. Similarly, if there is more than 20% fibrosis seen on the scan. Patients who have UIP pattern ILD in systemic sclerosis, their prognosis is also worse off compared to patients with non-UIP pattern ILD. Coming to the investigation of these patients, so lung function is usually the first non-invasive test we do. The chart here is showing at the top in pink. I don't know whether you can see my cursor here. This is normal. And the curve here is the restrictive pattern, which we see in systemic sclerosis or other ILDs. This is the shape of the curve is pretty same as the normal, but it is a miniature. And the shape is preserved because the FEV1 to FVC ratio is preserved compared to obstructive disease where the curve is pretty flat. This is a slightly busy slide. I put a few scans here. The one on the top left here is just to really demonstrate the difference between ground glass opacity and consolidation. So in the left part of this lung, upper part of the lung here is ground glass opacity, which is coming across as haziness. However, we can still see the underlying lung architecture and parenchyma. Immediately below that, we see this air bronchogram and very dense area. This is consolidation because we cannot really make out the underlying lung parenchyma here. The next on the right side middle picture is showing a very mild form of, excuse me, mild form of ground glass opacity and some septal thickening, little bit progressive change on the right side. The bottom left picture is of UIP, and then the picture in the middle is of NSIP. And I put them side to side just to highlight the difference between UIP pattern and NSIP pattern really. In UIP pattern, the hallmark is subpleural process and then posterior predominance. There is septal thickening, architectural destruction, which then manifests as what we call as honeycomb formation. On the other hand, in NSIP, the ground glass opacity does not have any preponderance of for any specific area, and it can be in any part of the lung. As in here, it is diffusely involving really all parts of the lobes on both sides. Although there is a little bit of septal thickening, however, there is no frank fibrotic architectural destruction as we see on the left side. And the picture on the right side is just to really demonstrate that when patients present very late, then it's very difficult to really figure out what was the initial ILD process, because this picture here is just showing extensive lung damage and destruction due to ILD, which could have started as ground glass opacities or may have been a UIP from the outset. This is the flow diagram to screen patients and identify those patients who should be treated. So screening should be tri-modal really. If we just focus on symptoms or chest x-ray, then we might miss a lot of patients. As we have just seen in one of the previous slides, ILD is pretty common. And chest x-ray is a poor screening test really. It's not very sensitive, picking up interstitial, particularly early changes. So the first thing is to establish whether or not they have ILD, and we do lung function test. FVC has been the most widely studied parameter, but obviously DLCO is very, very useful. Lung ultrasound hopefully in future would be very useful, but at the moment we heavily rely on HRCT. So those patients who we think and established after HRCT do not have systemic sclerosis, ILD, depending on their risks, we may choose to do lung function every 6 months or so, or maybe every 1 to 2 years. And then during the course of that, if we have any suspicion of ILD, then we do an HRCT. If we see HRCT showing ILD, then those patients should be carefully assessed and selected for treatment, and they should be followed up with HRCT about disease progression. So how do we select those patients who have ILD with SSC and whether or not they should be treated? We know that there are certain parameters which help us differentiate those patients who would develop progressive disease or who are at risk of developing progressive disease. For example, those patients who at the outset of illness have impaired lung function, and the cutoff for that is FVC of less than 70%. If, however, they have normal FVC, for example, if you have a patient with 90% FVC, but in 6 months' time on follow-up, his FVC has now dropped to 78%, it is still higher than 70% cutoff. However, because it has declined by 12%, that in itself is an indication for treatment. Similarly, patients who have more than 20% fibrosis on HRCT, or patients who have lesser degree of fibrosis on HRCT but impaired lung function should also be offered treatment. And then there's category of patients who have other risks for progressive disease, as we just saw in one of the previous slides. The treatment and management process is really very complex, and there should be very active and very significant communication between rheumatologist, pulmonologist, a radiologist, and if we have the facility of a highly specialized pharmacist, because these patients are going to be on pretty nasty cytotoxic drugs with significant side effects and all that, which sometimes are difficult to differentiate from the disease process itself. So if we have the help of a specialist pharmacist, that's really quite a bonus. Generally, in terms of management, some general considerations, and that is again weighing the risk of treatment progression versus the types, the toxicity associated with the drugs. We usually treat patients when they have significant symptoms or they have a risk of disease progression. Gastroesophageal reflux disease needs special consideration, not just because it causes distressing symptoms, but we know that this in itself is an independent risk factor for progression of fibrosis, and due to that, it's a poor prognostic marker. Smoking cessation must be addressed at any and every opportunity. These patients should be routinely offered annual influenza and pneumonia vaccine. Although there is no established, the role of pulmonary rehabilitation has not yet been established in CTD or SSC related ILD, but extrapolating data from other ILDs, I think there is possibility of some role for pulmonary rehabilitation in this group of patients. We like to prognosticate these patients, and various models have been studied. The saddle model has recently been validated and is pretty straightforward, simple to use, and we can see that there is considerable mortality difference if your SATA score is 6 to 7 compared to low score of 0 to 3. Now, how do we select treatment? Patients have been treated with steroids over the years, and there's always a concern and risk of what we call as scleroderma renal crisis. As you saw in one of the previous slides, it used to be the top cause of death in systemic sclerosis patients, but fortunately, it has now significantly declined because of increased recognition of this abnormality. Steroids, however, are not contraindicated, but you need to be very, very careful in selecting the patients. Um, Steroids do not really have very robust randomized placebo-controlled evidence, and most of the data has been from a retrospective or smaller, poorly designed studies, perhaps. Um, and that's why there was always a need for more robust, more evidence-based treatment, which came in the form of SLS trial, SLS1 trial, which was comparison of cyclophosphamide with placebo. And we found that cyclophosphamide did significantly, although modestly, I think 2.5%, but improved the FVC after 1 year of treatment. The benefit, however, did not sustain more than 1 year after stopping the treatment. But I think a very significant finding was also that patients with poorer lung function actually benefited most. It just underpins that we need to be very careful with patient selection, and patients who have poorer lung function have most benefit to gain. Cyclophosphamide, however, is a very cytotoxic drug with considerable side effects and all that. So there was always a search for a better alternative, which came in the form of mycophenolate, which was studied in SLS2 versus cyclophosphamide. And it was proven that it is non-inferior to cyclophosphamide, but more importantly, and significantly, we found that it is much better tolerated with much better safety profile compared to cyclophosphamide, and many centers now preferably use mycophenolate compared to cyclophosphamide. First trial was to study azathioprine after induction with cyclophosphamide, intravenous cyclophosphamide. And although there were some benefits, however, it did not meet the statistical significance, which I think was due to poorly designed study and due to small sample size. But most, a very significant finding from this came in the form of the fact that IV cyclophosphamide is much better tolerated compared to oral cyclophosphamide. And although we can't base evidence on this trial for azathioprine, but it's believed that azathioprine does have a role as an adjuvant therapy, particularly in patients who have drug intolerance. Moving to next class of drug, the ones we have discussed previously are disease-modifying or immune modulator drugs. This is a census trial which studies nintedanib, which is an antifibrotic TKI, and basically it established it has shown promise in smaller studies in mixed ILDs. So this led to this trial where it was studied in systemic sclerosis ILD patients versus placebo, and it reduced a relative risk of FVC decline by 44% compared to placebo. And more importantly, very well tolerated drug with over 80% completing the study of more than 500 patients. And also another significant finding was that the effect was same in patients whether or not they were taking mycophenolate. So this obviously opens an opportunity for combination therapy. In-build trial was on nintedanib, but this was on patients with different types of ILDs. And again, it showed similar results. UIP patients had slightly worse outcome compared to non-UIP patients, but nevertheless, nintedanib did significantly reduce the risk of lung function decline. Tocilizumab is FDA licensed and is used in patients as a rescue in patients who have progressive disease. As I said earlier, azathioprine, I think, does have a role in carefully selected patients, particularly those who have drug intolerance. Two exciting studies are hopefully going to be published later this year. One is SLS3, which will be studying combined mycophenolate and pirfenidone versus mycophenolate monotherapy. And the other one is Recital, which is studying rituximab against IV cyclophosphamide for CTDs. And these patients some of these patients do have systemic sclerosis. So hopefully we'll have the results soon. Although obviously we are still waiting for more robust evidence, but we do use rituximab in patients for rescue who fail to respond to first-line drugs. So this is really the summary slide that when you have a patient with systemic sclerosis, you screen them with spirometry, lung function, and HRCT. If they do not have interstitial lung disease, then depending on their risks, you may choose to follow up them with lung function, maybe 3 to 6 months, although doing them 3 monthly will be very, very expensive. However, if we risk stratify them, then we will be able to identify those patients who need more frequent testing. And amongst patients who have ILD, if patient has limited disease, then we risk stratify them, look at the risk factors for disease progression. And if they have risks, then we treat them. If they don't have risks, then we follow them up with lung function test. The patients who have either extensive disease or risk factors with limited disease should be offered monotherapy. Hopefully in future we will have more evidence and we might become more aggressive and starting them on combination therapy to begin with. But at the moment, most people would consider just monotherapy. And if their scan shows that they have predominantly ground glass opacities as opposed to established fibrosis, then the first line would be mycophenolate or cyclophosphamide, depending on costs and logistics and experience. If they have established fibrosis, then we use antifibrotic nintedanib and then follow them up accordingly. If, however, those patients show progressive disease, then we move to the we move to the combination therapy with mycophenolate or cyclophosphamide plus nintedanib. And this combination therapy, as said, is being studied in SLS3, where pirfenidone will be studied. And then obviously, unfortunately, if patients still show progressive disease, then options are either we recruit them in clinical trials or we rescue them with rituximab or tocilizumab. Autologous stem cell transplantation is an exciting development and has shown promising results in small scale studies. So there is hope that it would be a part of therapy in future. Unfortunately, I don't think we have any lung transplant center in Pakistan, but obviously, depending on your patient's resources, this is certainly an option. And palliative care, really, when everything fails, because they have significant morbidity and their symptoms need addressing. Very quickly, moving to systemic sclerosis associated pulmonary hypertension. This is considered essentially pretty similar from management point of view as primary pulmonary hypertension. And these patients should be referred to a center with expertise in pulmonary hypertension and perhaps lung transplant. Again, the stem cell transplant might offer some hope for these patients. Methotrexate, rheumatoid, and ILD. This is a very interesting one over the years. Actually, we have grown in our medical career believing that methotrexate induces ILD, and lots of patients with rheumatoid developing ILD, we used to stop methotrexate. But there is now increasing awareness and understanding that methotrexate pneumonitis is actually pretty rare, and it usually occurs in the initial part of treatment, usually within 12 months or so after initiation. The predominant feature is ground glass opacities. There's been a recent prospective study on more than 2,000 patients, which established that rheumatoid-associated ILD was actually less common in patients who were on methotrexate. So 4.8% who never took methotrexate compared to 2.5% of patients who were actually taking methotrexate. So we can say that perhaps methotrexate is actually associated with a longer time to development of ILD, and it is no longer routine practice really to stop methotrexate in rheumatoid patients with ILD who have actually reasonably well controlled arthritis and other symptoms on methotrexate. So in summary, we should screen patients, but screening should include symptoms, FVC, and HRCT. If we do not do HRCT, we'll be missing an awful lot of patients with ILD. We need to stratify patients according to their risk. That should then guide us which patients need more close monitoring or treatment. It should be considered for those patients who have significant disease or have significant risk factors for progression. We have to be very, very careful regarding the drug toxicity, because in trying to help patients with the disease process, we should try not to enhance or increase their misery due to these toxicities, and consider combination therapy when monotherapy fails. So that's it really. I hope this was useful. And again, I apologize for not being able physically to be there to answer your questions. But if you have any questions or comments, please feel free to drop me a line at my email. Thank you very much and have a nice rest of the conference.